questions on the state board, and almost every unit that has adults, you're going to be doing neurological assessments, sometimes right after surgery in the emergency room. So however you remember them, yes, you have your cueing sheet, but you should also have it up here. When I was in nursing school with Florence Nightingale, I remembered them through on Old Olympus, towering top, a fit in German, viewed some hops. And each of the letters of the first word reminds me of what I have to test for. Whatever method you use, that's fine. Some of them I can't repeat here, but you can use it if it helps you. So cranial nerve 1 is olfactory. And we're not going to have them sniff any special items, okay? But do know that with people that are older, their sense of smell diminishes, okay? And people who snort coke or even smoke, their sense of smell also diminishes. So we're going to do what is called a sniff test. So I'm going to ask you to block up one nostril and breathe in through here, and then block off that nostril and do the same thing. We're listening for patency. You can hear the airflow. That's called a sniff test. You're going to see that we're not going to do every particular test for each of the cranial nerves. You'll be here all day. So I'm going to point out the ones you need to use. Okay, the next one is the optic nerve, and I really should have you sitting closer to here, just facing me. With the optic nerve, we're checking for the red reflex, right? The trick here is making sure that you use your right hand and your right eye when you're looking at the patient's right eye. When you're looking at their left eye, you're using your left eye, and you're also then using your opposite hand to hold up the eyelid. Okay. I want you to look over my shoulder. Once you see the red reflex, you don't have to stay in there longer because we're not looking for the macula, we're not looking for the blood vessels. You just want to see the red reflex. When you see the red reflex, you know what? You know that there's nothing obstructing it. There's no opacities, cataracts developing because the light gets back to the retina. Look over my shoulder. And I see the red reflex, so positive red reflex. Also, with the optic nerve, we also want to check for confrontation, which is very subjective. I'm going to compare his vision against mine. So I'm going to ask you to cover up one eye. I cover up the opposite. When you see my fingers in your field of vision, I want you to say now. In the meantime, just focus in on my nose, okay? Okay, cover up the other eye. Same thing. Okay, so I'm going all 4 quadrants. It's very subjective. People who start to develop glaucoma might have a narrowing of their ability to see on the side. That's called confrontation. Okay, then the third cranial nerve is what?
Ocular Motor.
Ocular motor. Here's where we're checking for the extraocular muscle movements. No, I'm sorry. We're checking for direct and indirect constriction, right? First we'll do direct, so look at my nose, and I'm going to see how quickly, and luckily his irises are kind of blue. Mine are hard to see. And then I'm doing direct from the temporal side first. Then I want to do indirect. As I shine the light into his left eye, I'm looking at the right eye. And this is where I can write out pupils equal, accommodate, react, round, and react to light, pearly, okay? We're also looking to see if there's any ptosis or lid lag, drooping eyelids. He doesn't have that. So cranial nerve number 4 is what? Trochlear. And that's where we're checking for extraocular muscle movements and convergence. So here you can make an X or an H, but always start in the center. I don't want you to move your head. Just follow my finger with your eyes, okay? I I always come back to the center. I'm looking for nystagmus. We all have a little bit, you do too. A little bit of the muscle movement, jumping, but not too bad. Sometimes with children, you'll see that they have very bad nystagmus. And then we can also check for convergence by bringing the examiner's finger to the bridge of the nose. The eyes should go together. Next one is trigeminal, and this is where we're going to check for sensation. And if we check it here later on, when we come to the sensory system, we don't have to do it twice. So I can use a cotton ball, but I had one here. No, that's okay. And I'm going to ask you to close your eyes and point to where I'm touching with this cotton. Okay? You can open your eyes. So I could do that. You just do a few spots so that it counts for trigeminal. It also counts when you're checking for sensory, if you're looking at your cueing sheet. Also with the trigeminal, we want to check for the strength of the muscles of mastication, just like we were doing when we did the muscle skeletal. So you're going to put your thumbs in towards the tragus, fingers under the jaw, ask your client to open their mouth and move their jaw from side to side. Again, you're listening, you have a little bit of clicking. You're listening for any crepitus, which is clicking, or limitation of movement, okay? Abducens doesn't work by itself. It works with ocular motor, so we don't have to worry about that. Then comes facial. And with this, we want to look at symmetry. We're looking for any involuntary tics. We're looking for any edema or swelling of the face. And then we can check for symmetry by having our client do one of several things, just one. You can ask him to smile, puff out his cheeks, arch his eyebrows, grimace, just to make sure there's symmetry, okay? Then the next A is the acoustic or auditory. And we're not going to do the Weber or Renee, we're going to do the whisper test. And you're going to use a different word for each ear, and you're going to use a 2-syllable word. If they can't hear it the first time you say it a little louder the second time, but record it how to repeat it once, okay? So press it on the tragus on one side so the sound doesn't come. Block off so you can't see your lips. Okay. I didn't know if I had to repeat
I said toothpaste for a second.
Okay. Okay. Here we go. Okay. Good. All right. Yes.
So we're not doing the Weber and the Ryan.
No, you'll notice that I'm no.
Okay.
Notice that if we did just the 12 cranial nerves, we'd be here a long time. So we have too many things to go. Okay, so that was the acoustic. Is it glossopharyngeal next? Yeah. And with this, we're not going to try to get a gag reflex, but we want to see that the soft palate rises when the patient says ah on phonation. So I'm going to do glossopharyngeal, and I'm also going to do the 12th cranial nerve, hypoglossal, because I'll have my gloves on, and for hyperglossal, we're looking to make sure the tongue is midline, and tremors. We're looking for tremors as well. So while I have my gloves on, I'm going to skip to that one as well. But this time I'm doing the glossopharyngeal, and I'm going to depress his tongue, and I want you to say ah. All I'm doing is making sure the soft palate rises. Don't put the tongue blade all the way back so that they gag. With the glossopharyngeal, all I'm going to ask you to do is stick out your tongue, and I just want to make sure the tongue is midline. People who have strokes, the tongue will deviate on the side of their stroke. I'm also looking for tremors. Now, all of our tongues move a little bit, but I'm talking fasciculations that are really tremors, and he doesn't have that. Now, vagus works with the glossopharyngeal, so we're not going to do anything special with that. But we'll go to the spinal accessory, which is cranial nerve 11. So what I'd like you to do is to scrunch up your shoulders, and I'm going to try to prevent you from lowering. Okay? Now try to move my hand to this side. So cranial nerve 11 is intact. Now you gotta help me out if I'm forgetting something, because it's been a while since I've done this. The next is motor. And I can have him at the end walk, so I can check his gait and do Romberg at the very end. So he's not jumping on and off the exam table. But I can also do rapid movement. So I can have him either tap his index finger and thumbs together rapidly, open and close his fist rapidly, or pronate and supinate his hands on his lap rapidly. Patients with Parkinson's disease are able to do this at the beginning, but sort of like the ever-ready bunny, they kind of slow down. And that's one of the signs that you'll see with Parkinson's. So we'll just ask you to tap. Very good, very good. Now I'm going to ask you to touch with your finger, my finger, and then your nose. Okay, now close your eyes and do it again. You're going to try it first with your eyes open. Touch my finger. Okay, now do it. Yeah, but your finger and then your nose. Okay, all right, that's coordination. Then comes sensory, and we're checking for pain, right? So you're going to use a cotton tip applicator, break it in half. I'm going to tell my client with his eyes open, this is what sharp feels like. This is what dull feels like, okay? So I want now to close your eyes and you tell me what you feel. Okay, you can open your eyes, okay? We're not going to check for temperature. We'd only do that if they have problems discerning sharp and dull pain. We already did for the light sensation with the cotton ball, right? Let's see what else is here. Is it vibratory sensation? Okay. With that, you need a tuning fork. And what I'm going to do is in a minute, I'm going to ask you to close your eyes. And when you feel the vibration, I want you to say now. When it stops, say stops. Okay? What I'm going to do is I'll check corresponding joints. I'll try his elbows on both sides comparing, and I'll do one joint below the waist comparing. Older people have diminished responses to vibration, especially if they have diabetes mellitus in their lower extremities. Okay, close your eyes. Keep your eyes closed. Keep your eyes closed. That's vibratory sensation. Proprioception is a $25 word that refers to body position, figuring out where you are in the environment. So we're going to do this first with your eyes open, then eyes closed. So this is what it's going to feel like when you say up. This is what it feels like when you say down. Okay? You can close your eyes. Just relax. That's position sense. Okay, then there's stereogognosis. This is where you're checking the sensation of your client's use of their hands. And you're going to have them do one hand at a time with a different object. And you're going to ask your client to close their eyes. So in this hand, just use the fingers of this hand. Feel it and let me know what you think it is. Okay? And I'd be marking this down. That was his left hand. He was able to identify it. Okay? Feel that object? Is that your final answer? Safety pin? Yes. You can open your eyes. And you'll have these things available to you. So gait and Romberg I'll do at the end. The next are the deep tendon reflexes. When you're testing the reflexes above the waist, you're going to ask your client to clench their teeth and look away. That diverts them. And you're going to be using the sharp end of your reflex hammer. When it's below the waist, you have your client pull their hands apart, turn away, and you're using the blunt. We grade reflexes from 0 to +4. +4, I'll let some of you test me out because I have hyperactive reflexes. I'll give you a chance to see. So the first one, and you're going to compare one side to the other. First one we're going to do is called the brachioradialis. You need to know these words, so you're telling the examiner. So could you clench your teeth and look away? What I'm going to feel for and look for is some minor flexion of the wrist. This is the brachioradialis on the radial side. Clench your teeth. Okay, and you don't just keep hammering. If you don't get a response, that's okay. Okay, open your eyes. I want you to try it on me. You'll see the difference. Oh, okay. I'm not going to sit down just so that they can see. Feel it?
Yeah.
Okay. Hold it down. Okay? You don't have to keep going back. Yeah. Okay. So that's called what? Very good. The next one is biceps. You're going to have to practice. If you don't know how to use the reflex hammer, I'll be glad to stay and help you. With this, you're pressing your thumb over the antecubital space where we're taking our blood pressure. Relax their arm into your arm. You're going to hit with this sharp end. You're hitting your own thumb. Boy, you don't have very... Look this way. Relax. You try it on me. What are we looking for? We're looking for a little flexion. You might want to stand up. Hold my hand here, put your thumb, press it in hard.
Relax.
Try again. I felt
I
something.
felt the tendon go.
Very sharp.
Felt some.
Yeah.
Okay. And that one is called?
Brachial. Oh, no. Bicep.
Okay.
Triceps.
Okay. The next one is triceps. And you support the person's arm. What you're looking for is a little bit of extension. It's not going to come all the way up, but a little bit here. Okay, clench your teeth, look away. I don't know. There you go. You got +2 there. You want to try me? You didn't hit hard enough. It takes practice that you don't hit too hard, but hard enough. A little bit.
It's supposed to get extension, right?
Yeah, a little bit. Not going to go all the way up like that. Okay, well, you get the idea. And that one is called?
Triceps.
Okay, we'll get back up there. Now, for below the waist, we're going to do the knee or patella reflex next. You're going to ask your client to pull their hands apart and look away. You want to feel the patella. Right below the patella is an indentation. Feel your own. Because that's where you want to use the broad side of your reflex hammer. You don't want to stand in front of your client because they'll kick you, right? A little bit. A little bit. Feel it first, yeah. I start up here and I like that, so I can feel the indentation.
Sharp.
One side.
The ball.
Sharp. Yeah, yeah.
For anything below the waist, it's the broad side. Felt something. Yeah, and I have my clothes on. So that one is called what? Patella or knee. Okay. The next one is the Achilles. And normally, I don't know if you can take off your shoes for me. Oh, wow, okay. All right, what you want to do is press the patient's toes towards their nose, pull your hands apart, look the other way. You're going to hit above the ankle. Did you see?
Yeah.
Okay. And I'm just going to do the other one, the same thing. But while you're down here, we're going to do the plantar reflex that obtains the Babinski. And this is when you use this end of the reflex hammer. Do it quickly. We just want to make sure that the toes don't flare. That's fine in newborns. That's normal response for a Babinski. As long as it doesn't flare, we might see a little curling, but you're not going to see it like that. So now I'm going to ask you to walk towards the metal cabinet there and walk back. Oh, you make a perfect model. Now we're going to do the Romberg, which is for coordination. So you do this first while their eyes are open, feet just a little bit apart, and I stay here so I can be supportive. Now I want you to close your eyes. Now all of us sway a little bit, but if he has to move his feet to readjust, that's a positive Romberg, and that's not normal. Okay, you can sit up on that. You're an excellent, even though your reflexes weren't as, but everything was within normal. I know you complained of having a headache, and I think maybe just keeping a diary so we can see if it's related to anything in particular. Do you have any questions of me?
No.
Thank you for coming. Okay, let's see how we document this. Faster, because this system takes a lot of time, and you want to be able to complete it. If you're not, and you're going over time, they're going to cut you off. All right, olfactory, positive sniff test, optic, confrontation within normal limits. That's where I was checking his peripheral vision. Positive reflex bilaterally. You have to use the term bilaterally. Ocular motor, without ptosis or lid lag, pupils equal, accommodation, round, react to light. Don't just put perla there because the examiner needs to know what you're doing. Trochlear ELMs intact, positive convergence, no nystagmus. Trigeminal, strong muscles of mastication, able to accurately detect light touch. Facial, no drooping, no involuntary tics. Symmetrical when puffing out cheeks. Whatever you have them do, indicate it. Acoustic, positive whisper test. Right detected baseball, left detected Tuesday. Glossopharyngeal, soft palate rises on phonation. And I'd be documenting as I go, because I won't remember. Spinal accessory, can shrug shoulders and move head against resistance. Remember, I skipped down to hypoglossal and then eventually went back to spinal accessory. When you have your gloves on, you want to do both glossopharyngeal and hypoglossal together. Tongue midline, no tremors. Gait, smooth, effortless with arm swings. Rapid alternating movements within normal limits when tapping index finger to thumb. So if you use open and closing fist or pronating and supinating the palm, you need to indicate which you use. Finger to nose test, smoothly intact. Negative Romberg, which is good. Pain, able to detect dull and sharp sensation. Temperature, non-A. Light touch present, detected on face and hands, or hands and face and legs. Vibration sensation intact, upper extremities, decreased, I made this up, in lower extremities. Always do one comparison in the upper extremities above the waist for vibration and one below. Proprioception intact. Sterile diagnosis, detected quarter right palm, button, and left palm. Oh, I didn't do graphesthesia. The word means drawing or graft. And you want to tell your client that you're going to use a number system from 1 to 5. And you want to make sure that you're writing in the same direction as the client. If I write upside down, I doubt that he'll know what number I've written. So close your eyes, and I'm going to write a number in your left palm from 1 to 5.
Yeah.
too.
Uh-huh.
2.
Yep. Yeah, sure. Okay, that was graphesthesia. Then the last sheet were the reflexes, the tendon. Brachioradialis, his would have been +0 all the way.
This is +1 week.
+1 is some reaction. +0 would be no response at all. You're not going to keep going back till you get something. You try it, move on. +2 would be normal. I sometimes have a +3. The Babinski is when we do the plantar reflex and responses of Babinski, and that's when we go up the sole of the foot with the other end of the reflex in. Any questions about that? I don't think, don't be chewing gum. Okay, no for here that was fine, you know, in class, but you don't want to be like a cow in front of your client, right? All right, practice the blood pressures.
Thank you.